Occipito-cervical injuries are fatal injuries. If I see a patient with such an injury, I would assess the patient as per ATLS guidelines, do further investigations, and before that, I will immobilize the patient. That should be triple immobilization. I will take ample history regarding the patient, give adequate analgesia, and do a clinical sensory motor examination. If the patient is stable, I would prefer to go on for a CT scan with a 2 to 3 mm helical CT scan to identify the level of injury and associated ligamentous injury. I might need an MRI. Occipitocervical injuries can clearly be identified by a radiograph in which the distance from basion to posterior arch and opisthon to anterior arch is a ratio is created. If the ratio is more than 1, this is anterior cervical dislocation. If the ratio is less than 1, this is posterior and occipitocervical dislocation. In a stable patient, this can be managed with a rigid collar, but in unstable injuries, it will need fixation. The type of fixation is called occipitocervical fusion, and the basic marking is that superior neutral line and 2 centimeter lateral to the external occipital protuberance. This is because there is dural venous sinuses at the level of external occipital protuberance, which needs to be avoided.